Hello, welcome to this video. My name is Hannah. I'm a UK registered nurse, a university lecturer, and I've been an NMC OSCE programme lead, and I also provide independent one-to-one OSCE tuition and support. If you're new to my channel, I am trying to share lots of helpful videos, theory, advice and teaching to support you in your self-study for your OSCE exam. So please like, share and subscribe and join the growing number of nurses who have used my channel and passed their OSCE first time. So in this video, I'm going to do an APIE tutorial. So these are really popular on my channel, and I'm going to go through the APIE tutorial of the hernia. And we're going to look at assessment, priorities, we're going to look at care planning, medications to look out for, implementation, and potential recommendations in terms of your evaluation. Okay, so what is a hernia? So a hernia occurs when an internal part of the body basically pushes through either weakness in the muscle or the surrounding tissue wall and kind of protrudes through, and you get that kind of classic like hernia little lump. And you can get them in different sites, so inguinal, femoral, umbilical, incisional and hiatal. And if you want to learn a bit more about hernias, there is the NHS conditions website, which I'm going to show you because it's got a good summary of hernias and a little video as well. So NHS conditions website is really easy, laid out and gives you lots of information related to the different hernias. And at the bottom, there is a nice computer generated video which demonstrates the protrusion of that organ and how it is, and also how they are repaired as well. So that's a good resource for you. So there are some common risks that increase people's risk of getting a hernia. So any kind of increase in intra-abdominal pressure, that could be through like heavy lifting, and that's quite a common cause of hernia, especially in male population. Persistent coughing, having to really strain for bowel movements, so really persistent constipation as well. If you've generally just got a weak abdominal wall, there can be congenital defects as well. Obesity is a risk factor as well, potentially previous surgeries and generally just aging. So in your NMC scenario, obviously in the past medical history, look out and identify if there's any causative risk factors for your patient. Maybe something like obesity or history of kind of heavy lifting as well would put your patient at risk. So symptoms, so hernias are visible, so you have a visible bulge where that organ has protruded, and this normally they're in the abdomen or the groin. There can be pain and discomfort, so especially when bending, lifting or coughing, you know, when you're increasing that intra-abdominal pressure, and they can feel like a heaviness or pressure in the abdomen, and sometimes there's a burning or an aching sensation at the site. So hernias become really problematic if they develop into a strangulated hernia, and this is an emergency situation where they need to go to theatre as soon as possible. So what happens is where the organ has protruded, so the bowel, it then twists on itself and cuts off the blood supply, which leads to obviously necrotic tissue death within that part of the organ. So the symptoms of this is a very, very sudden and severe pain. They can get nausea and vomiting because obviously now there's a blockage in the digestive tract. So, you know, the normal flow of gastric contents is not going to be flowing through the bowel, so they can have quite a lot of severe vomiting. You have an absent bowel sound, so you don't hear those normal pops and gurgles in the bowel kind of, because obviously the movement stops throughout the bowel. You can get some skin discoloration over the hernia site as well, and patients can also present with a fever. So I think in the NMC OSCE exam, the patient has presented with strangulated hernia, so you would expect to have some of these symptoms. Your patient would be in quite severe pain with nausea and vomiting as well, and they need to go to theatre to have this repaired and fixed. So they need immediate surgical intervention normally. And what the surgeon will do is kind of reduce the herniated tissue, so reposition the organ which has come out back into where it should be, get rid of any dead tissue. So if there has been the strangulation has caused blood supply to stop, and then obviously that part of the organ will be ischemic and will need to be removed. And then they repair the hernia deficit, so they put normally a protective mesh or a reinforcement to stop the organ happening again. So why is this stuff important for your NMC OSCE exam, Hannah? You may be saying because you might be needing to give some information to your patient actor around the plan, for that they might ask you some questions around surgery, and you can be confident to be able to explain that to them, demonstrating your knowledge and obviously reassuring your patient around the procedure, which they will most probably going to go and have. So what would be our pre-op nursing interventions? So we'd want to keep these patients nil by mouth. Okay, so that's important because they're going to theatre. They should have some form of IV access, and we should be thinking about administering IV fluids and antibiotics as prescribed, and just monitoring for any signs of shock as well, especially if that bowel has become ischemic. So we're looking for those things such as low blood pressure, high heart rate, and low urine output. And we need to be preparing them for emergency surgery and also providing emotional support and well-being, because it can be quite a distressing situation for patients. They've got a lot of pain, but they're also going off to have surgery at quite short notice. So things to think about in terms of if you are in a pre-op situation, in that assessment station scenario, about information to give to your patient to prepare them for theatre. So what would be your assessment nursing priority? So obviously, as with all your APIE scenarios, you need to do your A2E assessment. That's exactly the same. We should definitely be looking out for any signs of sepsis and shock. So particularly, picking up on any changes in your circulation, pulse, blood pressure, CRT, pallor, and perfusion. We should definitely be monitoring fluid balance, so commencing a fluid input and output chart. The patient should be nil by mouth of theatre if that's the plan. And like I said, they will have maybe quite severe nausea and vomiting, so we might want to be managing that by escalating to the medics or surgeons for IV fluids and antiemetics. Pain assessment is going to be really appropriate here. Obviously, we need to pain assess all our APIE scenarios, but the patient should have or has had severe pain. So we might want to be just asking a couple more detailed questions in our pain assessment and disability. So your 0 to 10 severity, but also location, what makes it better, offering things to provide immediate comfort for that patient, assessing when and what analgesics they had last. Holistic assessment. So there's a potential here for there to be health promotion advice. We know hernias occur with an increased BMI. There might also be some other lifestyle advice like drinking and smoking. So look out for that advice, health promotion opportunities. There is psychological support and reassurance of theatre. Like I said, the patient might be quite anxious about going to theatre. So again, explaining the process, being able to reassure them what's going to happen, and give that support is really important. Just again, if you've got anyone going to theatre, it's important to check, are they carers, anybody at home, children, relatives, what depends at home, establishing next of kin and knowing who to contact in an emergency. And also don't forget about your spiritual needs. Some patients and people will have spiritual needs that they might want to have access to before going into an operating theatre as well. So offering spiritual support and multi-faith chaplaincy if they feel that they would like that. So just things to think about in terms of that broader holistic assessment. So planning, so with your surgical patients, there's always an opportunity for quite a few different care plans. Obviously, pain is very appropriate. Your patient might be in actual pain in your assessment station, in which case you can write your pain care plan. Sometimes in these surgical patients, they haven't got any pain in your assessment station, and that's because they've verbalised that they've had analgesics before you've got to them. That's fine, don't panic. These patients are still at risk of post-operative pain, okay, because they're going to go to theatre. So you can still write a pain care plan, but just modify your problem to, Albert is at risk of post-operative pain following repair of strangulated hernia. Don't worry if they haven't got an actual pain score. And then we've also got all our kind of risk of care plans, so risk of post-operative infection, risk of dehydration, they're vomiting, and are going to be nil by mouth. There's always that risk of post-operative bleeding, and they're going to be immobile for some time. They're going to be on the theatre table. They're obviously in pain. They're not going to be mobilising very much with that hernia at the moment, so they are at risk of pressure damage. Let's talk through a risk of wound infection care plan, because again, this could be relevant across all your surgical APIE scenarios. So we've got Albert is at risk of post-operative wound infection following the surgical repair of the hernia. That would be our problem. Our aim would be to promote wound healing and minimise the risk of infection to Albert. And reevaluation time would be 24 hours. Remember, with your wound healing, that's not going to be something that you want to be looking at and assessing, you know, every hour or so. We'd most probably be reviewing that wound 24, even sometimes 48 hours, and just checking that there's no signs of infection. So we don't need a really tight reevaluation time frame in. We're unlikely to see any differences, you know, within those first few hours of theatre anyway. So intervention, so we obviously got our consent, so we need to explain to Albert plan of care and gain consent. We would monitor and record Albert's vital signs and needs to post-operatively as per the needs to policy and escalate if showing any red flags for sepsis. We would change Albert's dressing as per the post-operative surgical instructions using a non-touch aseptic technique. We'd assess Albert's wound for signs of infection, so thinking about those things such as pain, redness, erythema, swelling, odour and exudate. We would administer prescribed antibiotics to Albert and monitor for effectiveness. Support Albert in maintaining personal hygiene post-operatively to reduce the risk of infection, especially good hand washing. We would be escalating to the surgical team if Albert's clinical condition deteriorated or the wound showed signs of infection. We could refer to infection control and tissue viability if clinical indicated. We could educate Albert on a healthy, balanced diet to support wound healing. We could also, you know, if showing signs of wound infection, we could take a wound swab as well. So thinking about all those things around kind of standard wound management, we'd write a care plan for post-op risk of infection. So on to implementation. So obviously you've got surgical patients, so we're most probably going to have some form of analgesics. So remember to ask your patient if they're in any pain. These could be as required medications, so just look out for those on your chart, looking out for your simple things such as paracetamol. This is surgical patient who they will most probably always have some form of post-operative antibiotics written up. So be vigilant and look out for your allergies in this scenario. So especially your psyllin-based antibiotics, your penicillin-based antibiotics. This can be a common medication chart where the patient is allergic to a penicillin-based antibiotic and they are written up for penicillin-based antibiotics. Remember, we can't give those penicillin-based antibiotics at all, and we'd need to code that at 10. But they can have the non-penicillin-based antibiotics, so things like your erythromycin, clindamycin, clarithromycin. So those ones are fine to give. We might have some antiemetics post-surgery as well, so your metoclopramide and your cyclizine. Again, look out for those on your as required. And there will be other medications depending on the past medical history of the patient in your APIE scenario. So common things such as your antihypertensives, amlodipine, sometimes there's a levothyroxine. So just be aware and vigilant of those normal medications depending on the patient's past medical history. Evaluation. So again, when I do my evaluation recommendations, it all depends on your scenario on the day and who you're handing over to. We might be handing over to the next nurse on shift, and we might be transferring them from the theatre to the ward. We could be discharging them at home and handing over to the community nurse for dressing review or kind of suture removal. So again, always read your scenario. Again, if we're handing over to nurse in these surgical APIE scenarios, there's those standard things that we'd always hand over. So we'd still want them to carry on with the post-operative observations and needs to monitoring. We'd want them to continue to monitor for post-operative complications such as infection, bleeding and thrombosis, continue to assess pain and administer analgesics as prescribed. We'd want them to continue to monitor fluid input and output, administration of antibiotics as prescribed. We'd want them to review the wound and the wound dressing and clarify when sutures need to be removed if you've got that information. We want to encourage early mobilisation to prevent any of those post-operative complications such as thrombosis and chest infections. We might have given some health promotion advice in our assessment station, might have identified things such as that increased BMI, smoking, drinking. So we'd want them to follow up with that health promotion advice. And, you know, if we have identified any other kind of social care issues, again, we'd want those things following up. So thinking about that safe handover nursing care for all your surgical patients, what would you want to be carrying on? You may be handing over because your patient's deteriorated post-operatively and you're handing over to a doctor or a medic or surgeon, in which case we need to identify from the scenario what is the most concerning thing, you know, what's happening to this patient. Are they showing signs of sepsis? Are they bleeding? Have they got severe post-operative pain? And our recommendations in those situations is we need that doctor to come and review that patient as soon as possible. So I hope that's helpful with you. These APIE tutorials are quite popular, so I'm glad they're supporting you with your OSCE. It's really good to learn the condition, understand how it presents, know what the symptoms are, know what the treatment is. You can use all this knowledge in your NMC OSCE exam, and it really goes a long way to supporting you in passing, but also developing and supporting your nursing knowledge for when you're working in the UK. I am available for tutoring, but I get really booked up in advance, several months in advance, only have a small capacity. I am launching my new e-learning platform as well, so look out for that when that drops soon, hopefully in the next week or so. Totally self-study e-learning platform, which I should do a separate video on as well.